Good morning, everyone. Thank you for being here. First of all, I would like to activate everyone. Could you please stand up and turn in your seat and sit down again so that everybody wakes up and is ready for the EEG? Turn on your seat, yeah, and sit down again. Great, thank you so much. So, my name is Joanna Berger. I'm an anesthesiologist and I'm also a researcher at the University of Bern. And I would like to thank the organization of the Congress to invite me here over today. I would also like to thank you in the audience for being here so early in the morning on a Saturday. And I would particularly like to thank those two ladies in the box over there in the back, because they are doing an excellent job for people like me who do not speak Slovenian, and make this Congress very interesting to me as well. So my topic is intraoperative EEG for all patients, Utopia or reality. Well, you probably know what my opinion is already, but I would like to have a bit of a hands up now, and I would like to know how many of you use EEG to monitor anesthesia on a daily basis. Okay, so all of you who have raised your hand can now leave the room, because this presentation is for everyone else. So how many of you have it in the hospital but do not use it regularly? Okay, a bit more show of hands, very good. And how many of you are also intensivists or take care of the ICU during the night time when you're on call? A bit more, good. And those who use TIVA, do you use a TCI model? Yes? Very good. And if you use a TCI model, is that an effect mode or a plasma mode? All those for effect mode? All those for plasma mode? Okay, very good. So we have a bit of discussion that we can start. So first of all, I would like to, so these are my disclosures. And these were the fire questions. So when Marco told me, well, you're going to try to convince the audience to use EEG, I thought, well, okay. So first of all, if everyone if every patient needs to use EEG, then I have to go back to basics. And I went to the ASA recommendations and saw, okay, so basic anesthesia monitoring. We have standard 1, a qualified anesthesiologist in the room. Well, I can do that, and surely you can too. Standard 2, oxygenation, pulse oximetry, yeah, we have that. Ventilation, ETCO2, yeah, I control that regularly. Circulation, continuous ECG and non-invasive blood pressure every 5 minutes, that's all in order. And temperature, yeah, I do that too. So I don't see anything on the brain here, so we could just wrap it up and leave, right? No brain monitoring, no recommendation from the ASA, so no need to monitor. Well, it's actually, when you look at this, it's rather interesting, and taking into account the lectures from the other speakers, particularly the one in TBI, that anesthesia, when you induce anesthesia, you give something to a normal patient with a normal brain, and suddenly the patient goes into a coma. He stops breathing, he loses consciousness, so he's not aware anymore, and he can't move at a surgeon's cut. So I can see some similarities with doing anesthesia and having some sort of brain injury. And the thing is, maybe anesthesia does do something to the brain to somehow make it, to make an injury. It's an aggression to the brain that we do every day to our patients, and that we do not monitor. So maybe we should start doing that. So there are lots of things we can do to monitor the brain. The most common at the moment is doing EEG. And when you think about EEG, you probably think about what you've learned in school, in medical school. Yeah, the EEG is used by neurologists, and it's great, for example, for picking up epileptic activity. You think EEG and you think epilepsy. Well, I don't need that, because it's very uncommon that I have a normal patient in the operating room having an epileptic seizure. But it does detect neural dysfunction at a reversible stage. Well, this is much closer to what I do every day. And it is sensitive to several common causes of brain injury, which could be something that anesthesia induces on patients. And particularly for me, what is important is that it's tightly linked to brain metabolism. And this I know for a fact, and you all know for a fact, because we all studied it, when we give hypnotics to patients, their brain metabolism decreases. So the con to all this story is that this kind of line, compared to an ECG or compared to an arterial line, is completely gibberish. I have no idea how to interpret this. And this is why people don't use it on a regular basis. So I don't intend this to be a 5-minute course on EEG, but I hope that I will give you enough detail so that you, on Monday, when you start working in your departments and you have some sort of brain monitoring device available, that you go and pick it up and just put the sensor on the patient and see what happens. So, we have seen that anesthesia maybe reduces brain metabolism. And this is a very interesting infographic. So on the left you have an awake brain firing away, all the neurons are very excited, and the consequence is that you have a trace that is with high frequency and low amplitude. Once you start giving medication to the patient, that activity slows, and this is something to be expected. You get slower and slower and slower waves. So on the right-hand side, you see how the brain waves are spinning at a much lower state, and you can see that because, you know, this brain wave here is much slower in terms, so compared to the other one. So how do we, this is a crash course on brain waves. We have several types of brain waves. They are distinguished by their frequency. The frequency of the brain waves is in hertz, and that means cycles per second. So you have very high frequencies, that's the gamma waves. Then you have the beta waves, which are frequent when we're in sort of like a superficial or awake state. And then you have the alpha waves that are, in a way, very similar to some patterns that you see when you have sleep. Then you have theta waves, and then you have the delta waves. And the delta waves, as you see, they're very slow, so they tell you that the patient is very deeply anesthetized. So how can we use this knowledge on our daily practice? So there are several devices that you can use. I am mostly familiar with the narcotrend and the BIS, and I think most of you will be too. But basically, the first thing that these devices give you is a number. And this number is based on the transformation of that previous brainwave that he's reading into a very complex, what they call mathematical model called Fourier analysis, to transform it into a number from 0 to 100. And this is basically, it's like a submarine. So when the submarine is on the surface, you have a 100, so that means the patient is fully awake. And as the submarine goes down, as the anesthesia goes deeper and deeper, the submarine goes down and the number also goes down into a state of full coma, which is 0. And if you have this notion, then you can take all the other devices and see, okay, what does this device tell me that is the actual good range of anesthesia? And for example, the BIS and the narcotrend tell you that it will be between 40 and 60 of that value. This is very good for someone who is starting, but it has a lot of limitations, and I can't go through those limitations now. But the thing is, there is more to just that number that we look at. You know, even the screen tells us more. So we have the index, which is rather good. It gives us a good notion of what the EEG, what's the processing of the EEG, what's the monitor is doing. But we have the raw EEG, also. And you can see right here, without not even doing this every day, that there is a slower wave pattern here than I've shown you initially on an awake patient. So you can compare just by eyeballing. And then, so that's the raw EEG, and then you have what it's called the spectrogram, which is basically how much of each wave is coming across. And in this case, you have a lot of alpha waves in red. So red is for a lot of them, and blue is for almost none or none. And you have a lot of delta waves. So the patient is really deep anesthetized, but he's in a state where he still has alpha waves, which are similar to sleep. So this is what you actually want to see. So, but how do we get into this spectrogram? So it's actually quite easy. You have this gibberish raw EEG trace. The components of the EEG are sort of like filtered, and the monitor can recognize, okay, in this gibberish there is a percentage of such waves and a percentage of such waves, which is here. So here it says there's a huge percentage of delta and an adequate percentage of alpha. It's like looking at the Alps from Slovenia. You know, you see, you know, this is a good mountain, this is not such a high mountain. And then you send a drone, and then you see the mountains from the top, and you see again, this is a huge mountain, and this is not such a big mountain. And that is a 3D spectrogram. But we do not have 3D spectrograms. This is mainly used in research. So what they do is they flip it over, and then they have the not so big mountain and the huge mountain. And this is what we see. That's how the spectrogram comes to exist. So this is a normal spectrogram from a total intravenous anesthesia TCI model. What do we see? We see right at the base the delta waves, and around between 8 and 12 hertz the so-called alpha power. Even if you have no idea of waves, you have to recognize one thing. It looks like the Spanish flag. So it's red, then yellow, and then red again. So if you're in Spain, if your patient is showing you that he's in Spain, he's good. You know, you don't have to worry. He's having a good vacation, and you can relax. And this Spanish flag can be seen in several different signatures independently of the anesthetic that you're using. I didn't bring ketamine here because ketamine is a bit, it doesn't show the same pattern. But for example, propofol is a classic Spanish flag. Sevoflurane, you see the upper part, the lower part, and then in the middle, a much more consistent, so the yellow part is just covered with red. And dexmedetomidine has sort of like this pattern that it goes red and then it stops, and then it goes red and then it stops. But it's still, you can still see the alpha and the Spanish flag here and here and here. Although propofol is the classic signature of the Spanish flag. So, if you want to know more, you go to the istap.org. That's a website for anesthesiologists that has loads of different presentations. And you can actually go and see, okay, I don't really know about this part, so I'm going to check that video. And this is basically from the Emery Brown group, and they're really good in teaching. So you just go here and you know more. So now, that was the 5-minute course on EEG. Now you tell me, what is happening here? Where is the red flag? Ah, okay, so the Spanish flag, here it goes, here yellow, here Spanish, but here there's something going on. And for some reason, so this was a spinal surgery under stable anesthesia and TCI with remifentanil and propofol, but something occurred here. We don't really know what it is, but I can imagine either a pain stimulus or a change of syringes. I have no idea, but something happened here that the patient here was no longer so deep, or was no longer in this with this alpha power. So this could be a concern of awareness. I mean, I have no idea what happened here. This is called the gap. And when you see the gap, you have to think, okay, is my patient too superficial, or is my patient too deep? So, but this shows you that there is a problem with your anesthesia, that you're no longer on your autopilot flying to Spain. The second aspect is, what if you're too deep with your anesthesia? This is a pattern that anyone can recognize. This is a pattern from 21 derivation EEG. So this is from, let's say, a classical EEG, but you see it everywhere. So you see sort of like a flat line, and then a burst, and then again a flat line, and then a burst, and then again a flat line, and a burst. And the suppression, this flat line, has to be over 0.5 seconds to be considered a suppression. But after that, you see a burst of activity. If you see this pattern, which you can see in the raw EEG, you know the patient is too deeply anesthetized. And as you probably are aware, the people who do intensive care, they are familiar with this pattern, but when they have a status epilepticus, so a patient which we cannot treat unless we induce a burst suppression coma with tiopental, and we all know that this is not a good thing for the brain, so in the anesthesia is also certainly not good. And if you go to the spectrogram, what you see in this area of flat line, so to speak, is just a black screen, so that's not good. Okay, so and now, why is it important that we actually check for burst suppression? I didn't bring a lot of data on purpose because I didn't want it to be a very heavy presentation, but I brought this meta-analysis that is rather recent, which tells us that there are a lot of studies that came up regarding what is the relationship with using the EEG and then having post-operative delirium in the PACU or in the ICU or in the intermediate care or in the ward. And as you can see, although this is, for a meta-analysis, it has a very high heterogeneity, and because of this negative study that's the ENGAGES study, it still shows that if you have an EEG-guided anesthesia instead of blind anesthesia, you will have a better outcome. So you will have less possibility of delirium in the postoperative period. And it's not shown here, but this is related to the amount of burst suppression time that the patient has been under, which means, and this is also very important, and this is because mainly we have the idea, okay, delirium is something of the old brains, and that's not the case, because all these studies show that if you have a burst suppression that is more than 10-15 minutes, even in younger patients, they will have a higher probability of developing delirium. So it is an independent factor, independent of age, independent of gender, and independent of surgery. And now, this is what I call the standards of anesthesia monitoring 2.0. So we've evolved from the standard of anesthesia monitoring from the ASA, and we now all talk about the ERAs and rapid recovery and enhanced recovery and such. And in these protocols, in these guidelines, there is now a standard recommendation to have brain monitoring. And I can just read out loud what these recommendations from 2020 say. So first of all, you have to consider EEG monitoring to inform anesthetic management. So this is a tool that will help you guide your anesthesia and basically let you know if you're going too superficial and with the possible effect of awareness, or going too deep and having burst suppression and eventually the risk of postoperative delirium. Then you have to be knowledgeable, or they suggest, of course, being knowledgeable in EEG interpretation. But I can guess that all of you now have pretty much a good clue of EEG interpretation. You can now look at a raw waveform, you can now look at a spectrogram, and you can now look at the indices, and you know how to use these technologies. Then use EEG to reduce the risk of awareness in patients receiving general anesthesia. And please remember, this is not just TIVA, this is also general anesthesia using volatiles or any other technique, dexmedetomidine combinations, whichever. And finally, consider the monitoring, and this is what I find at the moment particularly relevant. Consider the use of EEG monitoring to detect unintended burst suppression. So, finalizing my talk, monitoring the brain is actually a no-brainer. So we can do EEG monitoring to using raw EEG in the spectrogram, check for burst suppression, and this will help us prevent delirium, cognitive decline, and awareness. Thank you so much.